Have your, there will be opportunities for questions as we go on. We'll introduce the project right after we introduce ourselves. My name is Tom Fennell. I'm a consultant with SafeTech. I have been in the EMS industry for about 42 years legally. I grew up with an ambulance in my garage, and so I do have some illegal years in an ambulance as well. When I was strong enough to lift my end of the cot, my father and I would go on transfers together. But my career in EMS has spanned from a volunteer to basic life support leadership, advanced life support leadership, and today I serve as an officer of an organization that serves 2 states in ambulance, ground and air, and we have both modes of air, helicopter and fixed wing, and we have about 650 employees. I still live in a small town. My roots are in a small town, and the next person you're going to meet, Ben, is also rooted in a small town.
Thanks. We're going to start with the mic just to make sure everyone can hear okay. We'll see how kind of that goes. But so as Tom said, we want to introduce ourselves a little bit just to give you some context of where we kind of come from, especially with a project like this. So I also have been in EMS 32 years, not quite as long as Tom, but my first 15 years of my career were rural volunteer. And I was doing that while I was working in the family business and decided, I loved EMS. So when I got out of the family business, I wanted to do it full time. So the last basically 18 years, if you're doing the math or so, I've been running a full-time system that also serves a couple different states. I serve as the director of operations, but I started in that organization as an EMT, worked my way up to a paramedic, supervisor, manager, now director of operations. That service I started in, that was rural volunteer, I worked with up until 3 years ago. I had 27 years in that service. It was my hometown. It was a small town, and I worked there because I loved it. We often describe and explain a little bit of that background in all of these assessments that we do across the country, because we want communities, especially like yours, to understand that while we come from large organizations today, and the work and the data that we gathered is based on kind of, our experience in running a big system, we all understand what it's like to be part of a rural volunteer system, and we've not only lived it, experienced it, but been part of those for most of our careers as well. So we like to at least kind of introduce that a little bit so you know where our background comes from. A little bit just about SafeTech. If you're not familiar with us, many of you may have been involved in the interviews, so many of you may have heard this before, but we'll explain it for others who maybe haven't. SafeTech Solutions is this consultant company that really works in specifically EMS related topics and issues. We have a whole division that's kind of around education and leadership development, but then our other section is about this type of assessment work. And we do this work all across the country. So there are some assessments where we may do a small rural community such as yours. We'll do some assessments where we may do a whole county. We just wrapped one up in Summit County, Utah, which if you're familiar with that area, Deer Valley, Park City, we spent 9 months out there doing their assessment on building an EMS system. And then so we do a lot of statewide assessments. So we'll do the entire state. We're currently in phase 2 of Alaska. So you can imagine we want to talk about rural volunteer and rural EMS. Alaska is a state we're wrapping up part of phase 2 in right now. We've done the whole state of Nebraska. We've done the whole state of North Dakota, the whole state of Maine. So again, it ranges and it depends anything from statewide to countywide to maybe individually service-wide. So this is the work that Tom and I primarily do for SafeTech, is this type of assessment work. We'll talk a little bit about the project. I understand this will be a little small for some of you, but we'll certainly talk through it. If there's something that you see or can't read, we're happy to let you know what it says or talk about a little bit more. So really want to talk about this project. So what is the scope of the project? What were we asked to do? And give you, again, a little bit of kind of some context and background as we start to introduce the information. So this really was, for us, the scope was to try to come together and try to determine what could a system look like in this area. And specifically, we looked at the areas of Ely, we looked at the areas of Tower, we looked at the areas of Babbitt. So the idea was, if there were to be a system-wide approach to EMS in this area, what could it look like? The thing that's really important about this scope is that the hospital was very clear, as the ones that funded the project. They said, we don't believe that the EMS systems today are necessarily broken. We know they do a good job with 911. Their big challenge as a facility is when somebody comes to their facility and needs to go somewhere else, trying to get that higher level of care. So that interfacility transfer is often what we call it. How do we get somebody to Duluth if they need to go to Duluth? How do we get them maybe even to Virginia? How do we get them to Hibbing or down to the metro Minneapolis, St. Paul? And so that's one of the challenges that they've been struggling with, is being able to find a resource when they have a patient in their facility that they know needs a higher level of care. And because of the way the system is designed today, because of difficulty in finding and keeping people and staff, especially in models that are still using kind of a volunteer model, there's a little bit of uniqueness in each of the three that we looked at. But that was really what they said is there a way that we could do this differently? And they are really just looking for ideas. You know, if there was to be done something different, what might that look like? And that was really the core of the scope of the project that we were asked to look at. So as part of it, we looked at the three organizations, as well as we spent time working with the hospital. We didn't do an assessment of each ambulance. We weren't assessing Ely area ambulance. We weren't assessing Tower. We weren't assessing Babbitt. What we were trying to do is gather the data for all of the areas that are covered in the geographic area that we were looking at. What's the total volume? What's the total resources? What are the distances that we have to be aware of when looking at a project like this? So it was kind of a three-phase project. So what those three phases are, we're kind of in the beginning of phase 3. Phase 1 is where we just come on site and we interview as many people as we can. We want to learn as much about the system today as possible. What's the history behind it? Why is it operating that way today? What are the things that we need to be aware of? Are there any recreation or big industry that we need to be aware of that affects EMS? Obviously, you guys have a huge area out here that, you know, people come up in the tourist season. So big part of the project. So we spent a couple days, in this case, we spent 3 days on site, interviewed probably 20 to 30 people a day. And then we go back and gather all the other data. So we go into the state systems that track run numbers and run times and where the destinations are going to, and we get all the analytics. We reach out to get the finances to figure out where the organizations today sit in finances, try to gather all of that other kind of data so that we can start to put together the pieces and look at, you know, what does this whole area look like? That was kind of phase 1. Phase 2 is when we came back and simply presented our findings and our recommendations to the board of the hospital. We did that, I believe that was maybe last month, maybe a little earlier. And then phase 3 is really this part that says, once you've decided, you know, which direction to go or where they want to focus, we can come back and help implement some of those pieces, some of those recommendations. So in this case, one of the things the hospital said, the presentation that you gave to our board was great. We want the rest of the community to hear it. And we'd like you guys to share it because you guys did the work. So this is kind of that first step of phase 3 where we're coming back to kind of show you our findings, also our recommendations, but to give you guys a chance to ask questions, maybe questions of clarification. What are things that maybe we looked at, or where did some of the information come from? So we'll obviously give you guys a chance for that as well. At the goal of any one of our reports when we do an assessment like this is at the end of our report, based on our findings and recommendations, we want to basically build recommendations that come down to these 3 or 4 things. It's how can you in your area have an EMS system that's long-term reliable, viable, sustainable, and equitable. So all the people, no matter where you live, would get that same level of care. So at its core, that's what we use as our guiding principles when we try to do this work and put the data together. Sources of data, I kind of already talked about. Timelines. Our timeline was a little off. We certainly read about it as much as many of you may have as well. There's a few things why our timeline here was as long as it was. And in full transparency, some of it was difficult to get some of the data. I wouldn't say it was particularly any one person's fault or organization's fault. But often we found some areas where maybe a billing company had changed, and the previous billing company that had 5 years of data wasn't willing to share with us their data because that organization wasn't using them anymore. So we really struggled to get some data from some areas. We also wanted to make sure that the data that we got was valid. And so one of the things that we had heard was, you know, we continue to come back and ask a lot of the same questions on information we already had. And that's actually a really regular part of the process. So one of our jobs is to validate what we hear. So as you can imagine, when we're interviewing 20 to 30 people a day over 3 days, I may hear a story one way here, and then all of a sudden I hear a completely different story over here. So a lot of our job is to try to validate that. What's the actual story that's happening? And sometimes that mismatches with the data that we get. So we do often reach back out. There was also a small moment there where the scope may have changed. And I won't get into a lot of that, but there was conversations that were happening in your area where I think people were already starting to think about how about if we do start to work together? And so that led us down a different path that says, boy, if we do something different, how could you be a part of helping us do that? So there was probably a 3 to 4 week period there where we had shifted the scope of this project to something different. And in the end, it came back to this original scope. So there's a few things that kind of happened with our timeline. But again, just wanted to call that out and be transparent on that. So the presentation we've got, there's a lot of information here. We'll certainly kind of go through it, but at any time, if there's questions, feel free, or if there's something up there that you're not sure about or have a question about, you can certainly ask it when you want, or if you'd like, you can certainly kind of ask it at the end. But we'll definitely leave time at the end for any questions that you guys might have. And then again, I think methodology is something I've already kind of described, is how do we do the information? How do we get the information? How do we compile this report? And ultimately the guiding principles that I alluded to earlier. Try again. Mouse click. Okay. So again, this is kind of just the picture of what I've already explained to you. So we really looked at these 4 areas. We looked at the hospital, we looked at the 3 ambulance services. And you can see that a little bit of a shaded red around the general area that we looked at. So that's really where our focus was. Those 3 geographic areas that was provided EMS by whether it was Babbitt, Tower, or Ely, and then also just the needs of the hospital. So what is their patient volume? How many of their patients are being transported out? What's the potential run volume that a system might look like? So that's really what we focused all that. So what you'll see is a lot of our data that we're going to show went off the 2023 numbers. So we get 5 years of historical data to make sure that there's a pattern and it's not just some anomaly in one year or the other. With the 5 years of data, it all seemed to kind of match and flow. There was nothing that stood out there that was really unique. So then we kind of run most of our financial data and analysis off what was last year's data. So you'll see if we look at the whole system, the 2023 combined data was about 1,620 calls. And that's if we look at Tower, Babbitt, and Ely. So the total amount of calls that happens in this area. And then we have it broke down, if you can't read it, to how many is that per day per system. So it's about 3.6 calls a day. And if you just do the math, Babbitt, we didn't get a lot of data from Babbitt. And again, I'm not faulting Babbitt for it. So majority of the numbers we went on for Babbitt was with our verbal interviews that we had with Babbitt. We never actually saw their state data, but we were asking these questions in our verbal interviews. So we have a general idea of what those numbers were. So it's about 0.8 a day for Babbitt, 1.5 a day for Ely area ambulance service, 1.3 for Tower. So that's again where we get the total volume. Now on top of that, there's the transfer volume, and that's what we call hospital to hospital. So when the hospital is calling to request an EMS unit to transport somebody to somewhere else, what's that potential? That's a really critical number for lots of reasons. That's one of the numbers that really spearheaded this project, is how many times that they're needing to get patients, your community members, your neighbors, your family members out to another facility. So in our data that we got, there was 292, which is about 0.8 transfers a day. And then we were able to at least break down how many of those today are being handled by which ambulance service. So again, 199 from Ely, 17 by Babbitt, and 6 by Tower. So even in just this map, and if you go and add up those numbers, you'll notice it doesn't come to 292. That's because often even another ambulance service from outside of the area is coming in to take those transfers because the local provider isn't able to. And usually it's because they're busy on another call. Or maybe there is an issue with staffing that day and they don't have a second resource that they can handle sending that transfer out that could be gone for upwards of an hour and a half to 2 hours a day. Total system, there's 7 ambulances today that are kind of part of this system. So today these 3 areas operate with 7 vehicles. We realize they're not all staffed all the time. Many of them will have a spare, a backup vehicle, or maybe one that's dedicated just for interfacility transports. But there's 7 total today in the system.
Are all those transfers from Ely, or are some of them from Cook?
Those transfers are all from Ely. Yes, sir.
Can you tell the colors who's who?
The colors, sure. Tower is the light blue, Babbitt is the yellow, and Ely is the purple.
Who's green? Cook?
Who's green?
That's not in it.
That's
I
or.
realize that.
That's or. Pink is Cook, but they're not part of the.
I know what's blue.
Over there.
Yeah.
Boys Sport.
Okay, okay.
Yeah, again, feel free to ask. We realize that it's kind of small on the screen, so especially when it helps you as you think through these next slides that we're gonna go through. So we basically come up with key findings. So after all of our data and after all of our interviews, what did we find about the system as it exists today? So we're gonna tell you kind of our key findings, but based on our key findings, then we create recommendations. So these recommendations are based off of what we learned from all of that other data and information we gathered. So one is to create a vision for a single integrated EMS system design. Now, again, there's a lot of detail in this. What that means in the parentheses is that all stakeholders are in agreement. And that's the part where this decision is really going to come up to the communities. We're simply providing recommendations of what it could look like. But all of this is really up to you guys to decide what is it that you'd look like, what you would like it to look like. We'll talk about the finances, the numbers, the costs, and all of that. But one of the things that we believe needs to happen today is creating a single vision. Having all these communities together decide what do you want EMS to look like in this area. And that choice may be keep it as it is. If you all agree on that, that's a decision. It absolutely could be the decision. But we want to make sure that everyone is in agreement of that.
Yes.
Just to go back to you don't need to go back to the last slide, but I'm curious on how many non-transfers were there by an ambulance where there was nothing available and somebody had to drive themselves.
Right. We'll get to that. That's in the
Yeah.
presentation. We'll get to that in just a few slides. So if you could just hang with us, that'd be great.
But both of those questions, clearly you guys are aware of the challenges here. There are a number of patients that needed to go to another facility by ambulance and did not because there was no ambulance available. So we have that data. We'll incorporate it later. And I think the other question that somebody had asked over here about the transfers just from Ely, because there are other hospitals around here that are also looking for interfacility. And so whether or not you have a system that has the capacity to take on that other business, it's a source of revenue. And while EMS generally isn't something you think about as a business that's talking about revenue, it's a business, right? We need to make sure that our expenses and our revenues align. We got to be able to pay the staff and pay the bills. So if there are opportunities to capture additional run volume, that's where primarily most of your revenue comes from. And transfers are a big indicator of that. We'll show you the numbers in a bit. So create detailed design and implementation plan. So again, I'm going to just read this. Normally we don't like reading our slides, but I recognize how small it is. Efficient, performance-driven, ownership structure, oversight, and sustainably funded. So again, one of the recommendations is that some design needs to be created and implemented that has all these things in place. You know, who's going to own it? How is it going to get funded? How are we make sure it's going to be sustainable? Performance driven simply just means, are we reliable? Can we get the ambulance out the door in a reasonable amount of time? Can we get to the patient's side at a reasonable amount of time? So looking at some data to drive whether the system is operating effectively or not. And oversight, again, who's going to be in charge of it? Who's going to see it? One of our recommendations is that as a community, if you can get that single vision, you guys get to decide how would you like this to look. So I'll just, I can go on forever on each one of these, but I know it'll come up later. So create a transitional roadmap and timeline that honors local dedication and commitment. So we recognize, as Tom and I introduced ourselves, we both started in rural small town EMS systems. I understand the passion and the emotion that comes with being a part of an EMS system. We lived it in our own worlds. The system that I worked for 27 years went to another system. For lots of reasons. And I know what that felt like as an employee of that system for 27 years. But the reality of it is, in order to make sure the community gets the care that they need and that patients can be moved for the places that they need to go, we have to start looking at it more from this business sense and recognize there is going to be an emotional component, but we have to start looking at it differently. The history of why you have EMS today in the areas you do probably goes back 60 or 75 years. It's probably because when federal funding went away, your community said, we want to have an ambulance here. And you raised money and you bought trucks, whether it was corn feeds or smelt fries or, you know, however you do it. And they raised money, they bought trucks and they had a bunch of volunteers willing to staff them. But we know that today that's not long-term sustainable. And so we have to start thinking about what comes next for EMS in this geographic area. Incentivize participation in the new design and plan. So what this essentially means is that as a community or communities, if you agree to work together to build a system and there's funding behind it, whether it's through Joint Powers Board, whether it's through some of the state funding that might be available, whether it's through some other tax system, If part of the system doesn't want to be a part of it, then they shouldn't be incentivized to not be a part of it. We want to make sure that the organizations that come together to be part of it are incentivized to do so. And so there's only so much funding that's out there to provide for EMS. Building a system is, like it or not, the most efficient way to do EMS. And so if you can get all of your dollars into a system and reduce those redundancies, that's going to build you a better system at a better financial cost. But if other places don't want to be a part of that system, then we have to make that difficult decision is, do they get funding from us or not? We want to be part of the system. But again, all of these are our recommendations. I just want to be clear. There's a decision that you guys get to talk about and decide how you want to move forward. Assist unsustainable services and meeting immediate needs. So this is really one of the things that came up that was so critical is your systems today are at a bit of a dangerous level. Many of them are really struggling with staffing. Some of them are struggling financially. And what we want to also make sure is recommended that if you choose to build a vision and a system that comes together, that's the choice you make, that will take some time. Something needs to happen now in a more immediate future. How do we make sure that you don't have an ambulance system today whose roster is dependent on 3 people to make sure that door goes out? Because if one person gets hurt, you now don't have an ambulance in that area anymore. So we do need to recognize that there is some immediate needs that are happening in this area now. Interfacility patient transfers must be prioritized, valued, staffed, and resourced at the same level as 911 responses. Again, I'll read the small. So this goes to your question. 11% of the patients in this area that needed ambulance transport had to be sent by a personal vehicle due to the lack of an ambulance available. 11% had to go by vehicle when they needed an ambulance. It was the only way to get them to the hospital if they had to go to. So this is a bit of a difficult one in a few facets. One of it is that often EMS is really gauged or rated on how they provide 911 service. And clearly that's critically important. We believe, and we believe that that community should also have the same thought mindset that your interfacilities should be just as important as 911. In our organization where we operate, we do a lot of interfacility. And the way we share with our staff, and I think this hopefully will connect, is we tell them that we believe not only is interfacility as important as 911, in many cases, we actually believe it's more important. And the reason we believe it's more important is there's a lot of 911 calls that we go on that don't really need an ambulance. We'll come and we'll provide care and we'll transport you to the hospital and we're here for that, right? We'll do that. But there's a lot of 911s out there that don't require an ambulance. Interfacility transports are always deemed ambulance necessary because you've had a care provider, physician, a PA, whatever care you're providing at your facility has seen that patient and deemed them necessary to go to a higher level of care to get the treatment they need. And we don't see that on the pre-hospital side, the 911 side. So your interfacilities can often be more critical to be able to provide that service than just 911. Yes, sir.
Is there a statute or a law that makes the ambulance service take a 911 over an inter-facility? And which one trumps?
Yeah, 911, there is statute that says you must be able to respond. Tom would probably cite it better at the law, but basically without the ability or proof of pay. If they call, we have to come. With interfacility, services don't have to provide.
My point is, you have a patient at the hospital, cardiac arrest, needs to go to Duluth. I can't go because I have to stay for my 911 call.
Right, so there is a stipulation in the primary service area law that it's a couple different facets. One is that by holding this primary service area, I guess, right, if you will, every ambulance service has their own primary service area. That also includes those interfacility transfers, those are your responsibility. All right, now 911 trumps it. However, if it's an emergency transfer, the ambulance, the last ambulance in the service area can leave to take that transfer and have mutual aid cover their service area. Now, we understand up here, mutual aid comes from 20 to 30 miles away. Certainly understand that. And to take that last resource out of your community to do this, the interfacility transfer, the emergent interfacility transfer is a big jump. But that's all in how we'll if there's a desire to come together to talk about a system, how does the system flex to cover those interfacility transfers and emergency calls?
The reason I bring it up is if I was in the hospital and they said, I can't take you because I have to say 911, guess what I'm gonna do? I'm gonna call 911 and say, I need a ride.
Yeah. Well,
Right?
that's a nice thought. And I applaud your creativity. However, if then we get into trouble about, misuse of 911 and that's against the law and all
I
those
need
things.
it, that's not.
Right, but if it's an emergency, if it's an emergency, if it's not an emergency, then there's opportunities to make sure that there's coverage here at home before we go on the road, those types of things. And across the system, this is not just a challenge. I'll get to you, Dina. This is not just a challenge here. This is a challenge every place.
Right.
This is a challenge every place. And there are patients who are waiting in the emergency departments for hours and hours, days, just to find the right bed to go to and have a resource available to move. Dina.
He's the key.
That we try to look at joining together for transfers and EMS being it very.
Yeah, and again, if this is all part of the system discussion, so that if there is a desire to form a system, then we'll work with the state or we'll offer that guidance, I guess, to assure that we'd be able to join together in all areas and not just interfacilities. But yes, we understand that that's a challenge.
And we're gonna get to why the system approach allows that more seamlessly than what you have today. Because you do have challenges, not only from the state, but working together as a system, make sure that we leave the community covered while we're also able to take those interfacilities. So you'll see with our system designs, how that will show up. So here are some of the key observations. We'll just go through these. I won't elaborate on every single one of them unless you have questions, but the tense and often confrontational relationships between some of the stakeholders is likely the single greatest challenge facing the current system and the development of a future system. So this is one of the difficult parts of the job. Our job is after 3 days of interviews to just mirror back what we saw and to mirror back what we heard. And there certainly has been some confrontation amongst, and they could be I'm not just talking about EMS organizations, it could be elected officials, it could be just community members, it could be staff, it could be all sorts of reasons, but there's definitely some of that tenseness that showed up. And I'll be honest, it's not surprising. We see it almost everywhere we go. It's not that you're very unique in that, but it is often one of those barriers and one of those challenges that we're gonna have to figure out how to overcome if the option is to move forward with the system. As operating today, the current EMS system's long-term sustainability is in question. So again, as we met with the 3 services, each had some uniqueness about them that was difficult. And with those difficulties, it's the concern about can they continue to sustain the way they are today? The way they are today, whether it's through staffing, whether it was financial, or whether it was just long-term planning, there was risk in each of them in one way or the other. So the concern is today the systems, something needs to happen. Whether you choose to follow our recommendations or you find another way as a community to come together to support EMS, that's really, again, up to you guys to decide. But we know that as it's operating today, based on the numbers we saw, the data we saw, all the pieces that come together, it's in question about whether it's long-term sustainable. EMS is a vital and desirable element of healthcare and quality of life expected by citizens and tourists. This may seem very obvious. We don't always say this in our presentations. We have done assessments in communities where, as we've met with interviewees, people have said, you know, we don't need an ambulance here. We've got one 6 miles down the road, or we've got this, and so, or we've had some out in the plain states where they said, we knew that when we moved out here, we were giving up some luxuries. We don't have a Walmart, we don't have a Target, we don't have cellular service. We realized that if something happens, we may not get an ambulance. Because part of these areas that we're talking about, their struggle is how do they fund it? And when you go to the communities and say, are you willing to fund it? The answer was no. And so this isn't always something that we put in a bullet point, but here clearly it was. So again, I just want to overemphasize why it's in here, because you may look at that and go, well, duh, but we don't always see that. Throughout every interview we had, every community meeting we had, or the people that we met with, all of them said, we want EMS, we need EMS. And again, in your data shows it, how rural you are up here. If you didn't have it in this area, EMS would be a long ways away. So something that definitely was valued and desired. Workforce recruitment retention is and likely will continue to be a major challenge. And this is happening across the board. And it's not even just public safety. We know that finding people and keeping people is a challenge. Public safety seems to have taken that up a notch and slightly more difficult. And then you talk about your geographic area and you guys have taken it up another notch. And so it is a challenge, and that is going to be one of those challenges. So you'll see how we weave this, this key finding, this observation into why some of our recommendations are what they are. How can we do a better job of getting through some of these difficult areas? There's a lack of consensus around the specifics of EMS in northern St. Louis Lake County, who funds it, who ensures the provision of services, who governs it, and who operates it. And all this means is when we met people and said, what would you like to see? It was all across the board. So the community today as it stands, lots of different ideas, lots of different thoughts, lots of different opinions, and in some cases, many very strongly opinioned. And so today there is just lack of consensus from the communities we met with of what should it look like. Hopefully some of the things that our work can offer is giving this outside view in of what we believe some of the more successful models could look like if you choose to do it. Gathering and leveraging data may be helpful and likely will be essential. Again, we just need to be able to have the data. What is the volume? What are your response times? How many runs are we missing? How many patients are going by private vehicle? I mean, that data is going to be key to try to figure out how does the system get designed? Where do you have ambulances? Where don't you have ambulances? How do you deploy them? The data is going to be really important because you have such a large geographic area. Interfacility transportation needs are not being met. And I think we've already talked about that. It was one of the concerns of the hospital. How do we get people out? You guys have already asked the questions. We've already shown you the data of 11% not getting an ambulance when they needed one. The current funding, both fee for service and public tax support, does not support the current needs. And again, we just know by looking at the financials, there's only so much that we can bill for fee for service. We'll talk a little bit about the federal reimbursement model and what that looks like, because it is one of the big challenges. So if you're not familiar with how that works, it's a huge concern with EMS. It doesn't fund the system as it is. That's why many places like you often have some sort of a joint powers board, a taxing district, some other mechanism to help offset those costs. But what we know today is how the funding is working today isn't working. So how do we do something different? Unclear if current EMS agencies would consider being part of a new system. Again, I already talked about it. I'm not judging any of you, but are we willing to come together and work? That's a big challenge. Today, the answer is we don't know. We're not sure if you guys would be interested. I think a lot of it depends on how you might want to structure it, fund it, what it might look like. Yes.
And I have to leave because I have another meeting at
Sure.
5:30, but we, state representative for this area, we just passed a statute that is gonna create some of these issues, the bigger districts. We're gonna look at what's the best way. They have these sprinter, what do you guys?
Sprint vehicles, and we have that in here.
That they wanna experiment with us up here and see how that works. There's different. Everyone's trying to figure out, because we're just a testing.
Right.
Because they've been doing them in Otter Tail County and that and everything. So it's nothing new. It's just that we as a legislature kind of are way more open right now.
Right.
Someone can find a better way.
Yeah.
Real listen and the cast of characters that are down there now, we're all together on this, trying to solve this.
Yeah, absolutely.
There's no one saying, well, that costs too much money, or it's kind of right now, like, how can we assure?
Right.
I represent Northland, 45 minutes to an ambulance. That's how long it takes an ambulance to get.
Yeah.
Just put that into your.
Yeah, the state legislators certainly took a lot of initiative this year, and we'll talk about that a little bit because some of the numbers have come out, at least the preliminary numbers of what that might look like for this area. There's just certainly this concept of the sprint card. You put a paramedic in a vehicle separate from the ambulance. We will talk about that as one of the models.
Yeah.
And then even on the national level, we both work with the AAA, the American Ambulance Association. So we met with Pete Stauber, Congressman Stauber, Congressman Finstead. So even at the federal level, they're also recognizing, or I should say, at least their offices like yours is also recognizing this and saying, how can we do more and be more
Yeah.
involved, which is great. Yeah, change the Medicare system. That's my first goal.
That's the next.
We can talk for 30 minutes out in the parking lot.
That's the next guy.
Tom, you take over. I'm gonna grab
Thank
it.
you.
But we will talk about the funding and why it is such a challenge. So again, appreciate that.
Thank you.
So the new system may require some to give up power and control. And again, we just want to be transparent. We can't just come here and say, get your 3 trucks to your ambulance services and get them to work together and then we leave. We understand that there's challenges simply just to that. There's the pride in having Ely area ambulance service on the side of the ambulance. There's pride in Tower being on the side of the ambulance, same with Babbitt. And so when you talk about changing that, it means that there's giving up a little bit of power, a little bit of control. And we recognize that that's not a simple thing to ask. So we just call it out that we realize that will be one of the challenges and hopes in one that we can work together to get through. So we're going to talk a little bit about why we believe a system approach is important, because when you see the different models that are out there, we'll show you which ones that we recommend and which ones we don't recommend, and we'll tell you why. But we will just be very open and upfront here to tell you that the system approach we believe is the best direction to go, and there's some key reasons why. These are the key reasons. So certainly it helps with some duplication. Today with 3 ambulance services, you have 3 leaders, you have 3 people ordering supplies, potentially from different vendors. You've got 3 different vehicles that are maintenance on vehicles. You've got everything is duplicated. So certainly it eliminates some of that duplication. Expenses are increasing. So if we continue to do it today in a model that's less efficient, it's only going to get worse as expenses are going to go up. Reimbursement is falling and likely will continue to fall. So there's a few other things out there that we are concerned about in the industry of EMS that we may lose even more funding from the feds that we're getting today. So there's a few things. There's one out there called the No Surprises Act. EMS ambulance was specifically eliminated from this rule when it first came out. It was for air medical, helicopter, but we're now on the radar because we were excluded. And if that happens, that could wipe out a bunch of our reimbursement. And the other is the potential for the VA. If we transport a VA patient, those benefits were often covered and covered at a reasonable rate. There's talk that the VA now wants to change that rate to the Medicare rate. The Medicare rate is 1/10 of what it costs to run an ambulance call. So if we lose those VA reimbursements to the Medicare wage, we're going to continue to lose more money. So certainly reimbursement will continue to be a problem. Volunteerism is unlikely to be a viable staffing model moving forward. Kind of alluded to that. We understand why you have that system today in some areas, or you have maybe a version of that. They don't necessarily do it for free, but they're not getting a living wage doing it. So we're kind of trying to create a Band-Aid there, but we know that that's not long-term sustainable. Finding and keeping staff is likely going to be more difficult than ever. Today, the 3 EMS systems in hospital compete for similar resources. At its core, what we mean is people. You all are trying to find people. The hospital's trying to staff, Babbitt's trying to staff, Ely's trying to staff, Tower's trying to staff. Right now, you're all fighting for those resumes and applications and interviews. As a single system, you become hired as part of a system, and now we're not competing for them. Interfacility transportation needs are not being met. Again, we've kind of talked about that quite a bit. Revenues can be maximized, duplication can be reduced, and cost-based reimbursement could be leveraged. We'll talk about what cost-based reimbursement means. At its core, that's one of the critical pieces of why we believe a system in this area is likely your best option. And that's not the case in every area we go to. But because you have a hospital where you have it, and it's defined as critical access, that could be a game changer for a reimbursement standpoint. We'll talk about that in a couple slides. So here's the things to keys to sustainability. A new system or operator will need. If you do it, this is what you're going to need. You'll need all the call volumes. We ran the numbers as a system. That system has to get all of those 911 calls because that's how we ran the numbers. It has to get all of those transfers. So as a system, if one service isn't a part of it and that run volume isn't part of the system, it changes the financial side of it. So in order for it to be a system, they've got to have everybody involved. All the interfacility transport. So again, we got to stop giving away those transports or having them go by private vehicle. We need to capture those calls to help fund the system, and rates that maximize revenues. So we'll talk a little bit about rates today because of 3 systems, they all charge something different. And there's areas to improve and increase your rates And we'll talk about what the range is today in this area versus what the national average is, and you'll see the mismatch there. So as a system, they could work together to make sure that rates can be maximized to what's allowable. Missing any of the above will require a larger subsidy to replace the lost revenue. So again, if some of the call volume didn't exist, it just means that the community is gonna have to come up with that gap in money. If some of the transfers get missed, there's gonna be a gap in the finances. It's gotta come from somewhere else. However, that would work out in this area. And even with all of these, there may still be a public subsidy that's gonna be needed. So we'll talk, this is the legislative funding. So there's money that's out there. Have you guys seen the numbers yet? Okay, so it's not a lot. It helps, right? I'm not gonna. Yes, it's not even the end numbers, it's projected numbers. So yes, there is some money coming, but there's still hoops to go through to get it. You may not end up getting all of it. The numbers may change, but even if you get those numbers, it would put another Band-Aid on your current challenges. None of them are creating a long-term funding source. It's a one-time funding. It will allow you to get through maybe the next year, depending on how Ely's paying versus how Tower's paying their staff. But it is not going to solve this issue 2, 3, 4, 5 years from now. So here's the possible models. We'll go through them. You'll see we tried to look at as many different options that were out there. There are some options that we evaluated that we didn't put in here because they didn't seem to make any sense. But if you're curious about a model that you didn't see, ask us. We'll talk about maybe why it wasn't up here. So here's the first. So system design 1, and this is what we would recommend if you came to us and said, how would you recommend we do it? So it's a possible system would be system owned by Ely-Bloomenson Hospital. Now I realize that that in a sense could be a sensitive statement, but we want to talk about why it's so important. This comes back to that ability to bill and get Medicare reimbursement, to get this cost-based reimbursement back. Something that if it's owned by any other entity, you will not get cost-based reimbursement, which changes the finances. We have it on the slide, but I will explain it. Because Ely-Bloomenson is a critical access hospital, if the system was owned by Ely, and if Ely held the license, they could hold the license with their address at the hospital, which then allows them to get cost-based reimbursement for expenses incurred by the hospital. Generally speaking, that reimbursement is 101% of the cost, which means they could get back 101% of their expenses, which is salary dollars, medications, anything that is under their license because it's part of the hospital could get 101% reimbursed. Right now, to just paint the picture, your systems today get about 30% reimbursed. That changes everything when you talk about how to pay for the system. So we recognize, again, it's a sensitive subject. We didn't come into this to simply say, give it to the hospital. But if you want to be able to fund the system and a system that can create full-time opportunity, it's going to be important. Oh, 35 miles, what did I say?
No.
Did I say 25?
No. I just wanted to. Oh, so the system, coming back to the hospital being the owner of the system needs to be the system, because if an ambulance service is within 35 miles of another ambulance service, then that cancels out the critical access. So if it was one license and there were substations in Tower and Babbitt, now that's one license. And so that does meet the criteria of critical access. Now, it was brought up earlier about, well, that's the EMSRB wasn't going to let us do this. Those are things that we would help you with the EMSRB. We'd be able to work with Patty and if this was the desired goal, a demonstrated need, and then somehow working things out as far as the territory that's going to be covered. But the 35 miles in the system and all the players in the system need to be a part of this in order for that cost-based reimbursement to kick in.
I brought that up to you at our meeting at 35 miles. We couldn't do it because, like you just said, because of Tower and Babbitt.
Right.
And I tried and we did make some calls, put a 45 or 50 miles where we'd be the only one.
Yeah, and that's where that changes, because I agree. We had to look at it too. We had to look at it to make sure what we believed was correct. So we went back and did the research and confirmed. As long as the hospital owns a license, their address will be the stamping point of where that 35 begins. but they will let you create substations under one license. So you can have a station in Babbitt and a station in Tower, but your license is at the hospital, which allows to get that reimbursement. It's Medicare, yep, yep. So they will pay it at that higher rate for critical access. Medicaid fund, I think we separated Medicaid.
Medicaid is a state program.
Now, about 60, thanks, Patty. So there's a few things here, and I may jump ahead, but I'll skip past it faster in the slides when we get to it. But again, because it's a good question. This only applies to your Medicare patients. So you're not gonna get 101% back on every single call you go on. But if it's a Medicare patient, you will get reimbursed for that patient. Your Medicare, we have it up here, it's somewhere in the 60%, I think. So. No,
Could you repeat the question so we can?
Yeah, I'm sorry. You asked about Medicare Advantage. Yeah, because there's Medicare Advantage plans, and does that apply? It doesn't. So we also, when we show you the finances and how we came up with the numbers of what would the system get in revenue, what would the system pay in expenses, we broke it down based on if you did it through a critical access reimbursement model versus if you did another model. So you can see the numbers and why the others are less efficient when it comes to financial sustainability. But we also recognize that, you know, we don't just create a budget that then says every patient you take is going to get 101% reimbursement. When we did a very detailed financial analysis that we don't have on this because that alone was like a 2-hour presentation. But the gist of it was this, is we recognize that you might not also get 101 on every patient. So we also broke it down as what if you got 75% back on those patients? What if you got 60% back on those patients? What if you got 50? So again, we did all of our numbers very conservatively, recognizing that you're not simply just going to get 101 on every patient. So there's a enormous amount of financial analysis that goes behind the scenes when we build the spreadsheets that you'll see here.
If you have a patient that's only Medicare, you lose money on it. They don't have a secondary.
Today.
Sure, right.
Don't need this Medicare alone.
Right, you lose money, that's what I just said.
Yeah, exactly. And so, yes.
Why would you need anybody to have another insurance policy?
Yeah, some other, and even those you might only get 80%, but yeah, for those of you who maybe aren't familiar, you know, again, I'll just bring it up now, it's a valid point. For the sake of simple math, you transport a patient who's Medicare, your bill, let's say it's $1,200. You send it to Medicare and they go, well, that's cute, here's your 257. And you can't balance bill the patient. And so again, it's designed for, you know, helping those folks that are on fixed incomes. There's a reason for it, but from an EMS operation standpoint, when 60-some% of your patients are Medicare and you're getting back cents on the dollar for what you're billing, that's one of the challenges that we're seeing today. That was kind of my humor to your representative about let's fix the Medicare system. So anyway, here's what the system looks like. That was a long tangent on simply the first sentence of why we believe that would be the best option for ownership. So 2 staffed ALS ambulances. So when we say ALS, we mean there's a paramedic in the truck. 2 staffed ALS ambulances in Ely. You'd have one that would be primary for 911. You'd have another one that would be available then to take your transfers. You'd have 1 staffed ALS in Tower. So these are full-time staffed. So they're paid a living wage, full-time, can make a living off of it with paramedics in Tower as well as in Babbitt. So the uniqueness to this is what we call dynamically deployed. And so what that essentially means is you have to work as a system. So if Tower sends their truck out on an interfacility transfer, they might be gone for 4 hours. And now if Tower gets a 911 call, we don't want Tower to be left without an ambulance. So I'm saying Ely. If Ely leaves on a 911 call, we may need Tower to shift and come back up to this area, or maybe it's Babbitt, depending on some staging locations that are strategically placed. This is often what does happen in big, busy metro systems, but it's even more viable in the rural system. Because in the rural system, we have large areas of geography to have to cover. So where is the most likelihood of that next call? What's the busiest area? How do we make sure we have a resource as close to it as possible while still covering the other area? So the other thing is, you know, some folks will say, boy, you're not going to get my folks to get up in the middle of the night and go drive halfway between Tower and Ely to cover. The difference here is we're talking about full-time staff with a living wage. This is their job. They're not worried about waking up in the morning and having to go to their other job because they're volunteering on the ambulance. So you build a system that part of the work is you may have to move to cover. So this is system design one. We'll come back to it when we show a few other things, but this is number one. Here's my pros and cons, which I probably just went through with you. Again, you get a full-time paramedic and EMT in the entire area. So all three of the areas we're looking at, Babbitt, Tower, Ely, you'll have full-time trucks. Meets the interfacility need because you have a dedicated truck for interfacility, but you also have three other trucks. So if there's a second call that comes in, another truck could still take that second interfacility. You still have two trucks in the area to provide the 911 system. Under the Ely ownership, you would get that 101% cost reimbursement on the Medicare patients. Based on current call volume, it would not need additional capacity for some time. Now, what we mean by capacity is you will have a system that's slightly overbuilt. 4 full-time trucks in this area is probably more than you need, but because of the geography and how long your calls take, especially the transfers, you lose the truck for 4 hours on a transfer. But what this means is you could get busier and have more growth and not have to add another ambulance to the system for quite some time, because you have capacity to take on and absorb other calls. So this builds you a plan into the future. Because they're owned by the hospital, they could potentially do work in the hospital. Again, that's the finite detail. Do you choose to put them in the hospital? How does that work? How do we make sure they have downtime and that they still have rest time? Lots of things to still factor in, but it could be part of the way that provides the hospital some resources, keeps the skills and talents up for the EMS folks, whether they're medic or EMT. So there's an opportunity there as well. This continuation of care, they're working together both in the pre-hospital environment as well as once they arrive at the hospital. The hospital today has all of this infrastructure. The administrative side of how to run a business. They don't today have an EMS division, but they have HR, they have administration, they have billing, they have finance, they have payroll, they have all of that already. So you have some efficiencies there. And when we ran the numbers, it appears to cover your expenses with possibly even having a net margin. Meaning you could do it with enough at the end of the year to set aside. You have some capital equipment, you have some reserves set aside. So if we do it in this model, if we use hospital-based reimbursement, there's an opportunity the system would pay for itself. So there are some cons. It's the highest cost because we're talking about 4 trucks all full-time with paramedics in each truck. So it's expensive, but under this model, we believe it can potentially show a net revenue. One of the difficulties, well, you'll have to find those paramedics. Where are you going to find 4 paramedics to work 24 hours a day in this area? The hope is you build a system and again, a compensation model that gives them something to want to be a part of. It would require bases with crew accommodations in each location. So today, the areas you even have today don't necessarily have crew accommodations. Ely's got a nice spot. Babbitt's kind of got a space. Tower doesn't. So if we're going to do this 24-hour crews that are at the base ready to go, quick response times, we need a place for them to go. So there's a con to that. There'll be a little bit of upfront cost.
So how many total ambulances are there in the 3 services now?
7.
7.
Yeah.
And this proposes 4.
So, yeah, exactly. 4 staff. So that's the question is Dina says, what would happen to those 4? Depending on how this model is structured, today you are a nonprofit, and so nonprofits can generally dissolve and they donate theirs to another nonprofit. The hospital's a nonprofit. So those resources can become part of the new system. But if there's an organization that doesn't want to be a part of it and we lose those resources, there may be some upfront costs. Yes.
How many total FTEs is that with 2 and Ely?
Yeah, the math is 8.4 FTEs per truck. So multiply that by 4. So it'd be 8, 16, 24, 32, be about 34 FTEs. And then that's just the staff 24/7. Then you want to have some casual sick calls, vacation time, injuries, right? Yeah.
So that's 34.
Nope, half and half, EMTs and paramedics.
And just to understand, an FTE is 40 hours a week. So if your system wants to be built to do, I guess they call it a Kelly shift, 24 on, 48 off. That's 56 hours a week. So that's 1.2, 1.4 FTE. So that you can see the numbers start to dwindle as far as the actual bodies that you need based on the schedule that you might want to.
Yeah, but again, great questions because it would ideally every truck is every ambulance is a medic and an EMT. So half of them should be medics, half would be EMTs. But as a con, we've got to be able to find those medics to be able to work up at this area. So our other models show different versions of this. Maybe we're worried we can't find that. So we have kind of a 1.5 in here, and this is the same system, but if it's owned by anybody other than the hospital. And so 2 staff trucks, all the same stuff, 1 ALS in Tower, 1 ALS in Babbitt, 2 here in Ely. So again, don't recommend it, but we'll show you some of the pros and cons here of it. So one of the pros is it still provides ALS to the area, meets the interfacility needs. Staffing wise, it's all the same. Wouldn't need additional capacity, meaning you'd have additional downtime. So if it got busier over time, you wouldn't have to add an ambulance anytime soon. But the cons, again, this is still the highest of the model. Finding the people, it's all the same cons. The difference here is that the worry about if you're not owned by the hospital, you lose that infrastructure, you lose the cost-based reimbursement. You kind of lose the ability to leverage EMS skills when not on call. So can they practice in the ER and actually keep up when they have some downtime? Some of your areas today have less than a call a day. So how do we make sure they keep those skills up? Being able to work in an ER is certainly a good opportunity, and some choose to take advantage of it, some don't. So again, model 1.5 is the same model, just owned by anybody other than the hospital. When we run the numbers, that one significantly loses money every year. You're in the red by a significant amount. And if that were to happen, then that subsidy has to come from somewhere. We can increase billing slightly, but the rest likely is gonna have to come from some community funding source, whether it's taxable, however you might decide to structure it. System design number 2. So this is 2 ambulances and 1 ALS quick response vehicle. So that's what the representative was talking about, is this QRV that we call it. So there's a paramedic in it that can move all around the area and provide ALS skills. They're not tied to one specific community. So they might be based in Ely, but then instead of having ALS paramedics in Babbitt and Tower, you put BLS. So now you only have 2, not only, I mean, not you don't have the medics, you have 2 EMTs now in Babbitt, you have 2 EMTs in Tower. So you're gonna reduce your overhead costs because you're paying slightly less for the EMT versus the medic. You don't have to find as many medics. So one of the benefits of this system is you still have the 2 ALS here, so they can provide the interfacility, they can do the 911s. The other areas we can reduce the cost slightly, and then that quick response medic is able to move around and kind of provide that ALS care to those other communities. So we'll talk about pros and cons on that one here in a second. So again, provides full-time ambulances in the entire area because you still have the 2 in Tower and you have 2 in Ely and Babbitt. Sorry, I said that backwards. 2 in Ely, 1 in Tower and Babbitt. You've got the chase vehicle that can provide ALS to those other areas, meets the interfacility needs. Based on the call volume, you would have the ability to get busier. It's a little less costly because of the EMT salary over the paramedic salary. And it requires less ALS paramedics. So you would have 1 in each ambulance here and 1 for the quick response vehicle. So it's 1 less paramedic per shift. So it does, hopefully it could help with that challenge of finding ALS providers up in the area. So here's the cons. It's just as much as model 1. When you put all the numbers together, because you actually are adding a person. Instead of having 8 people on, you now have 9 people on. Just so happens that it's 3 paramedics instead of 4. But when you add the extra person, it's just as costly. So it's just as much, and you lose the timeliness of paramedics to the areas of Tower and Babbitt because they'll be first responding with EMTs. So that ALS provider won't be there as quickly. There's a liability and practicality of whether you want somebody running around in a squad car all over the county. And I'm not saying that because they're bad drivers. I'm just saying, like, in the area that you're in, with the deer that you have, with the snowstorms and the weather that you have, having somebody come from Ely to Babbitt or Ely to Tower or Tower to Babbitt, it's a lot of driving to get to provide that care, and there is a liability to that. Finding ALS personnel is still one of the challenges with all of them, but would still require the base options that we talked about. But this also requires the most number of staff. So again, we're adding another person to the day-to-day roster, but we're also then creating a minimal savings of it. So design 3. This is 2 staff ALS trucks and a quick response vehicle in Ely, so same as the last one. The difference is we do a volunteer / part-time in Tower and a volunteer / part-time in Babbitt. So similar to kind of what they're doing today. So what this does is that we've still got a chase vehicle with a paramedic that can run around. We've still got 2 full staffs up here in Ely to be able to do the 911 here and to be able to do the transfers out of the hospital. We still have ambulances that are in these other 2 areas, but because we're not paying the same salary dollars, there's more of a savings in the cost. There are some pros and cons as well, but The glimpse, that's this third recommendation. Again, you'll see it's not our recommendation. It is a model. We put it out there, said this is an option for you. You could choose to do it, not one that we could generally recommend. And again, pros and cons, it's the least costly, because now we're talking about 2 of those trucks being still kind of volunteer staff, volunteer paid. ALS is provided through the chase vehicle, so you're still getting the resource out to the areas, just not based in the area. Still meets the interfacility need because you've got the 2 full-time trucks here. Cons, it relies on volunteer staffing. And again, this is just us mirroring back. We know today that's a challenge in the areas you have today. It's already difficult finding staff to do volunteer on the ambulance in those areas today. The ALS chase vehicle could arrive without transporting ambulance. So this is something, I worked in a chase vehicle system, worked in it for a long time. Tom did, and then one of our other consultants who did the behind the scenes work did. The challenge with doing an ALS chase vehicle by using volunteer ambulances, that paramedic may show up and an ambulance never shows up to meet him. So now you have a paramedic on scene with no ambulance. And so it is a reality of the challenge when we're still using some volunteer labor, is that we can't guarantee that second resource is coming.
But if you have something like this now, in the winter time up here, say, for example, Town of Morris, most of the homes are owned by stores. Get a call in there, need a plow, which we need all the time, who's gonna go in there and get them out? Somebody from Power, ours is gone or what? How do you, who's gonna plow that road out? Who's gonna pull them out while the ambulance is 2 miles down the road waiting for them?
Right.
Who's
Yeah.
gonna do that?
I mean, because the chase vehicle can get in, but the ambulance can't. Yeah.
Cause they don't get out of that ambulance.
Yeah.
Who's gonna go out there and get them out of there, plow and pull them all out here, pull them all out there? We have the biggest area to cover.
Yeah.
We go all the way to Stony, we go in the boundary waters. We have the most miles.
Yeah. Thank you for confirming why we don't recommend this one.
You go on these dirt roads.
Yeah, again, for you guys to consider, it is a model, not one we recommend. But if the goal is to say we can't go all in right now or want to do something different, it is an option to do today. It's not very different to what you're doing already. So you could kind of move to this system. Again, we're not recommending it, but this might be one that's easy to ease into because you're already doing kind of the volunteer BLS in 2 communities. Now we just change a little bit of the system, but again, it doesn't feel like for what you're saving, it's worth it in the overall providing of care to the community. Sure. And Dina's saying she believes it could actually cost more if you do that. So, and yeah, not worth it, which is again why we put it up there. So there's some financial considerations. We'll show you some of the numbers. If you have questions, we'll answer. We don't dig too deep into it here in this presentation. But there's multiple spreadsheets that kind of go through and calculate and tabulate all the numbers that we've been sharing with you about why we believe one is more financially sustainable than the other. But I'll let Tom kind of go through the financial side.
Thanks, Ben. All right, so under the financial part of this, we talked about the operations, we talked about system design and things like that. So now we talk about the business end of the ambulance service. So when we make assumptions, when we start drawing these plans up, we have to make some assumptions as far as the finances go. So the keys to sustainability in the recommended project that we had discussed already in option number 1 is that the call volume. Ben mentioned this earlier before, is that in order for this to succeed, we have to have the entire volume. We have to have all the 911s, all the interfacilities, and that's what's going to make this sustainable. The rates have to be maximized. We're going to talk a little bit about where your rates are today. We can't list all 3 of the rates because number 1, we didn't get them. But number 2, we don't want to, be accused of rate fixing and those types of things either. But what we can show you is what the rates that we saw here, and we're going to talk about the national averages, and you might be surprised a little bit on that. Mileage needs to be maximized, especially for interfacility transfers. So we're going to talk about the rate that you're charging for mileage today and what seems to be the more common rate or the acceptable rate across the country. Ensure that specialty care transport is used appropriately. This is a new base rate. This is a different base rate than what's being charged today, and it can only be charged for interfacility transfers. And it really applies anytime that the skill level goes above what the paramedic has been trained for in their original education. So again, it's interfacility only, but this is a much higher reimbursement rate from Medicare. When we talk about 65% of your patients, this is certainly a significant change. Active support of community stakeholders. This isn't a one-time thing that you're gonna say, yep, this is a good thing. This is gonna be a continuation. This has to be something that you as a community, you are the decision makers here. You as a community really have to get behind to say, this is something we want, this is something that we want to pursue, and this is something that we're going to perfect. So that's all going to be coming back to you all. Leading as a business. Yes, this is a business. Ambulance services are a business. We talk about certain performance indicators, shoot times. The community isn't going to be satisfied with 20 minutes to get an ambulance out the door if they're full-time employees. This has to be something that's respectable. You know, shoot time of 60 seconds, 2 minutes, those types of things are respectable. Response times, what's the time of the call to the time that the ambulance arrives on scene? And we certainly understand there's geographic challenges here, absolutely. But on average, what is that response time? What is that, and how can we measure that, and how can we show the community that we're actually providing this high level of care? Transfers are as important as 911. We talked about this. We keep continuing to talk about this because it's that important. Transfers are a financial windfall for an ambulance service, but they're also super important to the continuation of the healthcare system across this area. Finding and keeping the right people. I mentioned this at the board meeting a few weeks ago, is that you all live here. You all want to live here. There are other people who want to live here, and we have to find those people. We worked in a system in Montana. And this is where Ben talked about there's no Walmart, there's no movie theaters, there's no grocery store, those types of things. We interviewed a couple, and they were in their 80s. And they said they could drive home, and they live 35 minutes away from town, and it would be 3 hours before they saw an ambulance, a fire truck, or a law enforcement officer. 3 hours, and they were okay with that. They knew going out there. But they wanted to live there. That hospital that runs the ambulance service today, their recruiting method is amazing. They go after people who want to be outside, who want to live in the mountains, who want to hunt, who want to fish, who want to experience those things. They go after those people. And that's been their success. So there are people that want to live here. We just have to find those people. And the leader and the leadership team. Leadership is where this is going to be made or dropped. Leadership of a service has to be that inspirational person, has to be somebody who's going to get the troops rallied to make sure that everybody's on the same page and to really make it something that people want to be a part of. So leadership is something that is utmost importance in this EMS in order for it to be sustained. So some assumptions when we get into the numbers here, the assumptions is that we're not going to get any busier. All these services are going to stay the same. The volume is going to remain flat. The new system captures all the transfers. We talked about that already. Everything is coming into this new service. Expenses are based on ALS ambulances with EMT paramedic staffing. Ben talked about that in the system design and how that's all going to be part of the assumption. Each staffed ambulance is about $1 million operating expenses per year. When you just look at the FTE that's allocated to them and an hourly wage and benefits, it comes out to about $1 million. It's a lot of money, but it's a lot of people. The wages that we're projecting to start, a staffed BLS ambulance is at $735,000. ALS being $1 million, BLS being $735,000. Wages that we're projecting, and this is not from the wages that we collected from here, but we also did a regional survey. What the wages are being paid for EMTs and paramedics. We're recommending that a starting wage of $19.25 for an EMT and $25.75 for a paramedic. And then we consider 30% of the costs to be added into benefits. Okay, so that's time off, health insurance, so on and so on and so on.
That's on top of the 1925 and the 2575?
Yes, that's on top of that. That is not inclusive of that. The new rate projections, we're going to get into these a little bit more. BLS emergency, $1,500 for a 911, and ALS emergency, $2,500 for interfacility transfers and $40 a mile. Those rates are not out of line. We're going to show you that in the next slide. Administrative costs are figured at about 25% of the expenses. So we have to have that structure. We have to have the infrastructure to regulate the ambulance. We have to have a leader. The leader might not be somebody that's regularly going out on calls, but we have to account for that. We have to be able to account for maintenance on the vehicle. We have to account for supplies and those types of things. 35% of the revenue, 35% of the revenue is non-Medicare, which is estimated at recovering 50%. So we talked about Medicare being 65% of the patients that you serve today. Private pay or corporate insurance, those types of things are 35%. And what we're projecting, again, with the conservative approach that we did, was of that 35%, billing these new rates, we're only going to collect 50% of that. And you might think 50% is pretty low, but when we look at ambulance services that we operate, we're collecting about 39 cents on the dollar on average. So, and this is just this patient population of that 35%, we're projecting 50% revenue. And then 65% of the transports are Medicare. Yes, anything that's outside of Medicare. Medicare and medical assistance is equaling the 65% right now.
So your major insurances, are you getting recovery of only 50% from them or?
Yeah, it's amazing how some of the major insurance companies are following suit with Medicare. They want to pay Medicare rates. Ben talked about the VA being one of those. But then we also have this No Surprise Act, and some of the insurance companies already believe the No Surprise Act accounts for ground transports as well too. So the No Surprise Act is really, we could bill, let's say that's $2,500. And the insurance company, even though it's a private insurance person, the insurance company might look at this call and go, yeah, it's worth $1,500. And under the current law for the air ambulance providers, we cannot balance bill the patient for that extra money. That's being projected for ground too. That's being projected for ground. And so without that ability to balance bill, yeah, we're looking at about 50%. Again, these are conservative.
And an average, yeah, and conservative, right? So the average is if you look at all of your non-Medicare and you look at how much you bill out, the average is you're getting about 50% back. And some might be a high deductible HSA. The bill goes to the patient for the HSA and they don't pay that, you get nothing for it. So when you balance them all out, and again, the important part here is it's conservative. So when you look at the numbers that we put up, our numbers reflect these salaries, our numbers reflect these billing rates. And so if you take these salaries, these billing rates, these costs, administrative costs, all of that's what we did when we ran the budget that will show you whether we believe this is profitable or not profitable. So these are all factored in, but they are conservative. You might actually get more than 50% back. But if we created a budget that said, they probably get 80% back, and we're kind of just fluffing the numbers, and in reality, it's probably not what's happening. So we try to stay pretty conservative when we do.
So I'm sorry, Chuck had a question over here
I'm
first.
sorry.
Yeah, is there any discussion about loaded miles versus like on round trip? If we do a transport that load, we got a couple hundred miles and we only get reimbursed for 100 miles at 22 cents a mile.
Yeah,
Well,
well,
our government officials are getting.
yeah, first of all, your 22 cents a mile is very incorrect. But only loaded miles are what we can bill.
Yeah.
Only loaded miles, and that's the payer's response. But we're going to show you here what $40 a mile is going to give you.
Okay, how much is Medicare?
Medicare is going to reimburse, is it 27 or something like that?
Well,
26, 27, it's been like that for 29 years.
okay.
We've been talking to the age, trying to get more money for that. And then after 1 year, the building collectors will give up. And if you don't give your bill to the insurance companies that for 1 year, you don't pay it. So you got 1 year for the building collector and they'll tell you, forget it, we can't collect, they won't pay. Or in other words, if you have an ambulance bill after a year, you don't have to pay it, you stay lost.
Right, and that's why we're conservative in our numbers here. We're not telling you the 80%. Yes, you had a question.
I was just curious about billing companies. Do we all have the same billing companies for all three places?
No.
And are there differences between on what people are billing from the different areas?
Yes.
And how did you come up with your numbers? Did you use just one? or-
No, we're gonna come up with what we believe your rates should be at.
We looked at what current rates are in the area. And then we looked at what your rates should be at. Now, the billing companies, they all have different matrix that they go through as far as how much they're gonna charge you. And what their collection rate's gonna be, what they're going to do for you, those types of things. There's a lot of variety in this. But again, we're back to the system discussion. And if we had a system, would we need a billing company?
Right.
Would we, and I'm not gonna, we're not gonna, we didn't talk about what levels of services would be available from the hospital, but this is a resource. They have a billing company, they have a billing department within, they know how to bill, they know how to bill Medicare. So these are advantages of being part of a system.
So what is that loaded mile for Medicare then?
About $27,
$27.
somewhere in that area, but let's just talk about what the, yes, sir.
So, the hospital has its own department or they actually third party?
Hospital has their own billing department.
And EMS billing is different, but there's a lot of parallels, as you can imagine. A lot of hospital-based EMS systems do the billing. Some billing agencies, I don't remember what we got into here, but they charge as much as 13 to 15% of collected dollars. And so, I mean, that's a lot to give away right through the beginning. And I don't blame it. I know why they do it. Hospital billing is, or EMS billing is a very difficult, convoluted thing that if you do it wrong, Medicare can say, oh, you did that wrong, and we won't pay you for 6 months as a penalty. So I don't blame them for using an outside billing company. Often that's a good thing, but you could be more efficient and have it done through another operator, one that's part of your system. A lot of ability to recoup that money.
The hospital's a nonprofit.
And all the ambulance services are nonprofit. All right, so let's talk about the rates. Let's talk about your current mileage in this area is somewhere between $20 and $30 a mile. National average between 40 and 60. We used 40. We used $40 a mile for our projections. ALS non-emergency, we don't have that charge here. ALS emergency today in the area, $1,500 to $2,280. The national average is $2,500 to $3,500. The BLS emergency, BLS non-emergency, $850 to $1,100. We did not put the national average up here because we don't have a good solid BLS non-emergency national average. BLS emergency, $1,050 to $1,500. The national, you're pretty close. The national average is about $1,000 to $2,000. ALS 2 emergency. So there's ALS 1, which was the ALS emergency up on top. ALS 2 is when patient care gets a little bit more involved. There's multiple medications or certain procedures that are done. Then the ambulance service can charge ALS 2. In the area today, $1,700 to $2,400. National average, $3,000 to $4,000. So there's a lot of room there. Now, the specialty care transport, we talked about that earlier in the presentation. It's not charged today. This is for interfacility transfers only, and those transfers that meet that higher level of need. The national average is $3,500 to $4,500. Those are base rates. Those are not all inclusive. Those are base rates. So you take that base rate and you add the $40 a mile onto that. That's the entire bill. Medicare is only going to pay a certain percentage of that. Private insurance is going to pay a significant amount more.
What is an example of a critical transport?
A specialty care transport. So if we're moving a patient from this hospital to a hospital in Duluth that has pumps, IV pumps running, that could be considered a specialty care transfer. Somebody on a ventilator. We have transport ventilators now, somebody on a ventilator, that would be considered specialty care transfer. Things along those lines. Yes, well, it's actually a level above ALS.
But a lot of the medics are able to do it. And so the way they define it is if you didn't learn that skill in school, but you're asked to do it in the hospital, in the pre-hospital setting, it's considered SCT. So all the organizations that do it provide training. It's just not part of the core curriculum you get when you become a paramedic. IV pumps are not included in it. You can learn an IV pump in a couple hours. We know the medications and all the other pieces, that just putting it on a pump is different. Same with the ventilator, and there's a few other nuances too. But today we didn't find that, because these are all billing codes, right? So this just is something the billing department looks at. They see the chart, what was provided, what was treatment, and then they decide what code it is. So one of the things is we could not find an SCT code in any of the 3 services that we looked at today. So it's just an opportunity to potentially bill at a higher rate. Because we know you guys are taking patients out on vents. We know you're taking patients out on pumps. So it's an opportunity to capture some additional revenue.
So here's how it all lays out. If we look at those scenarios that we had outlined for you before, the top scenario, 4 ALS ambulances in expenses, and this is, let me read this down. We're assuming 65% Medicare. We're assuming the revenue includes 35% of commercial insurance collected at 50%. 911 mileage was a weighted average based on estimated mileage. Volunteer labor was an average of actual 2023 expenses from the 2 agencies that currently use volunteers and provide per diem compensation. Some critical factors to consider when we look at these numbers. This is providing all the transfers. Again, we talked about this. Without transfers, all models under the current reimbursement show significant financial loss. Okay? Without cost-based reimbursement, all full-time models, with cost-based reimbursement, all full-time models are viable. And the fly car or the chase car is not recommended as it does not provide scene to hospital transportation or hospital to hospital interfacility transfers. All right, so 4 ALS ambulances up on top, $4 million, current reimbursement, $1.4 million. 2 ALS ambulances, 2 BLS ambulances, the expenses, 3.5 million, 863,000 is currently reimbursed. And the expenses, these are what we're able to capture based on cost-based reimbursement. Okay, so the numbers in the black. The number that under the current structure that you might see a profit on is the volunteers, those 2 trucks that are volunteers. But we know volunteerism is not going to last. And it's not providing that higher level of care.
I want to just read it. This is how it's currently operated. So
Yes, this is
not-
current.
Not with cost-based reimbursement.
Right,
So
I'm sorry.
if any of these models today, as independent systems, not part of the hospital, not getting that benefit, you're showing significant losses in those 2. You'll have a little bit of a net, but on the bottom one, but it's because you're using volunteer labor.
So under the current structure, that's what you're going to see with those models. All right, organizational structure and ownership models.
Yeah, so we wanted to talk about, are there any questions on the financial side? It's one slide. We know there's so much detail behind it. What we showed you today is the reason we're recommending the hospital be the owner of the system is because that one will cover the expenses, that top line of $4 million with all the things that we showed you, and potentially still have some net revenue that can go away for reserves, capital expenses. So we know that one can be sustainable financially. We just simply wanted to show you up there, if you do any of those models without changing any of the structure today, they pretty much show a loss. So it can't be done unless it's done under the hospital with 101% cost-based reimbursement. So I just want to reiterate that and say it in a different way. But are there questions on that?
Well, we're a small area here. We can lose money, but you're saying that. How can Virginia lose a big outfit like that, lose 570,000 a year?
We didn't assess Virginia.
They lost 570,000.
They're a fire-based system. They run and operate a lot differently. That's about all I'll say about that for our fire folks in the room. So here's, again, yeah, sir.
You use the 101% reimbursement from Medicare. If we were to chase this route, what kind of assurances do we have that 5 years from now Medicare is going to be Doing that 101%.
We don't have any assurances today. Actually, we got challenges with Medicare that are going on right now in Washington DC because our Medicare extenders were set to expire December 31st of this year. Now, a Medicare extender for this service, for the services up here, pays 22.6% additional. So that's a huge dollar amount. But that's was set to expire December 31st of this year. Now, the Federal Ways and Means Committee kicked it out to September 30th of next year. So we got 9 more months out of the deal, but we're hoping still to get a bill passed by the end of the year, which will not only kick it out further, but also increase. Because Medicare's reimbursement, as you said, sir, Medicare's reimbursement has stayed flat, but our expenses have gone up. And so we have to be able to somehow start to bridge that gap. And that's what we're hoping for. The industry is hoping for, but we have absolutely no assurances. And the thing is that under this model, there's no assurances. Under the hospital model, there's no assurances. Under any other model, there's absolutely no assurances.
Yeah, I think that.
He just came out with a study in 36, Medicare is gonna be full.
The thing that we can talk about is that if anything changes with Medicare reimbursement for the negative, it's gonna affect any system you do. So even if you keep things the way they are, you're gonna end up being in a worse off position. So, but again, very valid question. Yes.
I know, I think I forgot that. I was wondering about, so say the cost for the entire everything was $100,000 short, did you kind of go through scenarios about how that would be handled? Like, is this 30% your responsibility or 20%? Or at the end of the year, it's all, or?
Yeah, one of our slides, and I realize we go through so many bullet points and so many slides. There's a slide on a bullet point that says, even with all these things in place, there might still be a need for some sort of community subsidy.
No, I get that. I guess I was just putting you that specific how.
Yeah, who would be responsible, right? So if all of a sudden you create a new system, becomes part of the hospital loses money, does the hospital absorb that? Or do they reach out to the communities? That's a question that's probably unknown. But it would be something that we likely would need to figure out is there still some type of a subsidy that comes from the community to help, whether it's for capital equipment purchases, things like that. But yeah, it's a question. Is if they take responsibility for it, what happens when it doesn't make money?
Are you familiar with how the laws of government state power has an ambulance service for each service? Other communities that we don't have say on.
Right.
We have to service them. Can't tell them what to do.
Yeah, and you can't force them to pay you.
Yeah.
Right. And that's I think part of the crux of what really initiated this work is we know that there are communities out there that are supposed to provide some sort of subsidy and haven't been. And I think with the folks that we met with or different people we talked to, many of them said, we want to support EMS, but we need to know where our money's going. And there's been worry that the system as it's designed today is not sustainable. So do we give our money now to a system that's not going to survive? Or do we really push the issue and incentivize participation and say, we've got money to provide, but we want to make sure it's going to something that will be here in the future. Yes, Dina. So Dina's asking about if this were to happen, can we work with the state to find some tax base? So yeah, and that might be, and that's the slide we're on right now, to be honest, is no, that's okay. It's again, we get it, and you don't want to forget your question, right? So, because here's the reality is, as a community, the folks that have to make the decisions on what you want your system to look like, there are multiple ways that this can be structured. And so, yes, we're recommending the hospital for all the reasons we've talked about, but you could choose to create a new nonprofit, a whole new nonprofit that absorbs in the others and takes on one license. So you could operate it like that. And we'll talk about pros and cons of each of these. You could create a new special ambulance district, which might give you some taxing authority. You could do the joint powers board, like today is operating some of the systems in the area, or you could turn it over to one of the current providers. Babbitt, just because I pick on Ely, Babbitt might say, we'll take on the responsibility. And it becomes Babbitt that kind of holds the license, so to speak, and then creates this larger system. So there are 5 ways that are the easy ones that you could look at and say, well, we agree with doing a system, but we want to structure it different than what you recommended. These are generally the 5 ways you could choose to do it. They each have some pros and cons. So again, pros of the hospital, I'll just rip through this because we've talked so much about it, but cost-based reimbursement. They have the infrastructure. They've got some of the community relationships already. Potential for an expanded role for EMS. They can do work in the hospital. Has a critical need. They have a real passion and desire to help find a solution. They're not forcing a solution of anybody. They're simply just saying, you know, can we bring you guys in to give us some ideas of what it could look like? But it's really not up to them. It's up to the communities to decide. But they have this critical need because they want to get their patients where they need to go. So they have this vested interest in figuring out how EMS can be better served in this community. Past EMS management, leadership experience. So they did in the past have EMS. So yes, there have been lots of leadership changes, of course there have, but they have run it in the past. Some cons of the hospital, this EMS hospital paradox, the short version is, it's different when all of a sudden you have EMTs and paramedics working for a hospital because they have to have downtime. They may end up on a 3 a.m. transfer to Duluth. We need to make sure that they're rested. If I'm a nurse, a CNA, a OB in the facility, I'm probably working my 8 or 12-hour shift. EMTs and paramedics might go sit in the other room and take a nap. And so there's this paradox when you work for a hospital system, but part of your job is making sure you're well rested. So it's just a challenge. We see that sometimes in hospital systems. Why do they get a TV and DVD and Xboxes? We don't get that, but it's part of the cost of readiness. There is no current EMS infrastructure, so they would still be building it kind of from the ground up. Startup costs could be difficult. If you guys build the system, we know that today there's locations that don't have housing for the crew. We'd have to get some housing. We'd have to maybe get some equipment. Unsure of long-term effect on the organization. So this goes with the question that you just asked. What happens if Medicare changes? We don't know, but when we call up, something could change that could affect this. And then will it remain a critical focus if the current leaders transition? So that's not only Patty, but the board. You know, the board of the hospital and Patty really wanted to try to create this initiative to just bring some ideas to the communities. And today they say, you know, we're open to anything. But what happens if that changes? You get a new board of directors, maybe you get a new leader at the hospital, they may say, well, we don't want it anymore. So it is a reality that today there's a huge influence and support from the hospital to help make this work. That could change.
Just on a point you made, question comes as to what has really changed since 2008, because the hospital had the ambulance, went to the joint powers members and convinced them to establish the nonprofit.
Right.
It worked pretty good till the pandemic, actually. Yeah. So,
well, I think you may have kind of answered your own question. So what he asked was what's different from 2008, because the hospital used to have it, now it went to this new system. We know a lot has changed in the past 16 years. So yeah, COVID certainly had an impact, but probably the biggest change is the decline in volunteerism. Being able to find folks that are willing to do this job for little or no money and be available 24 hours a day, see and do the things that they do, and generally still work another job because EMS doesn't pay their living expenses is something that's been a huge challenge. So, and the ability to have one license, Patty says.
Yeah. To have that critical access. Yeah.
Did you develop any numbers as far as veterans?
We did not. We just did not include the VA calls in the 65% that are covered by Medicare medical assistance.
Did you interview the clinic here, the VA clinic, maybe Minneapolis?
We did not interview Minneapolis. Our schedule, our interviews were basically set up by either folks at the hospital helped figure out key stakeholders. When we met with them, we asked them, who else should we talk to? So we tried to connect with as many as we could, even after hours, we'd run into people and just have conversations. But is your question more based about veterans needing care and not getting it? Or about the expenses of reimbursement for VA?
Reimbursement and the fact that we have a lot of veterans.
Yeah, and that's one of the challenges that we have to be aware of is, as we said, the VA is talking about changing reimbursement for EMS. And if that happens, it's not only an unfortunate disadvantage to the EMS system from a funding source, but it's an unfortunate result. Then the veterans lose the benefits that they're getting. And so it is one of the things that we put up there as an unknown. So operating today as 3 independent systems is more likely to feel the hit of that versus a system that's working together if something changes with VA reimbursement. Because you may have a large population up here, just like you have a large population of Medicare folks. So that when we factored in the run volume, that's why we wanted to see, we looked at the billing of all the services. So we looked at the runs, but we looked at how many were Medicare, how many were Medicaid, how many were private, how many were VA, because we need to know the true payer mix. If we just come up here and guess, well, maybe it's only 50% Medicare. And then we give you a budget that we think works and you go, well, we're 75% Medicare. The budget doesn't work. So we look at all of that data behind the scenes. So, new freestanding, again, pros and cons. If you decided to do a system and you just rather do a new nonprofit, it's certainly independent. So they can kind of create and design so much that they want. It would be, you know, starting from scratch gives you lots of opportunities. It's potential for an expanded role for EMS. Easy to grow and expand because they're kind of their own entity. It's usually not affected by elections. Depends on who you put on the board. You would need a board for a nonprofit. But when we do something that's more like joint powers or some of the municipal, you know, your elections are going to affect the decision makers. And so a nonprofit wouldn't necessarily have that same effect. It's easily accepted by grants and programs and tax exempt. So there's some benefits to tax exempt, but some of the cons is it is independent. So they don't have all those other resources they can draw off of. It's starting from scratch. It's also one of the cons. They got to build it from the ground up. They may not have EMS or leadership experience. So depending on, again, who that board is, that's really helped lead the vision for the system, might not have EMS experience or knowledge. No current EMS structure, starting from scratch. Startup costs could be large. So again, you got to buy and build everything because you're starting from scratch. Even if you buy the existing equipment from who's out there, they've got to be able to purchase that equipment. And then finding the right board members is so key to a successful nonprofit, especially when you're talking about EMS and how you're going to lead it. Doing a district, there's some pros and cons. Again, start from scratch. You can create it however you want. Potential for expanded role for EMS. They could possibly do more. Easily accepted by grants. Often has some sort of a taxing authority. So you could create some taxing authority through a special ambulance district. And it's got some of the other benefits of a governmental organization, just how they kind of operate as a district. Cons may not be independent. I mean, again, depends on your elected officials and who's there on the district board. You got to start from scratch. Difficult to grow it and expand it because you're usually stuck to a district boundaries. Could be affected by elections if you're being appointed to that role. No EMS leadership experience, no current EMS infrastructure. Startup costs will be large, limited control of the board. They're likely appointed elected officials from other areas. May feel like a duplication of taxation. If today you're already paying something and now they create a district that says now there's another tax. And the public would likely need to vote. So there'd have to be real consensus to see if they will approve a district to be started to be able to have that taxing authority. Joint Powers Board, some of you guys use this already today, so you may be familiar with it. Again, you can expand the role for EMS, accepted by grant programs. You have one taxing authority, may benefit as a governmental organization. There's currently one in place, so it represents the area and might the system might serve. So we already are familiar a little bit with how that system works today. May not be independent, again, because you got certain people that are going to be on the board. May be difficult to grow, can be affected by elections. It's a lot of all the same things that you'll see there. So there are some pros and cons to each, but, or one of the current providers simply is, again, does Ely just take it on and run it? Does Tower take it on and run it? So pros is you're already here, you're a current provider, you already have some of the infrastructure, you've already got some of the EMS leadership and management experiences. Cons, today, the way the systems operate, their expenses have been greater than revenues. So today, as it's been operated, it's not been financially sustainable. Volunteers are still in use in some of the systems, so it doesn't account for how do we get more of a regular full wage for folks. We know they're facing reimbursement challenges and they're not eligible for that cost-based reimbursement. So we just want to call out, there are options other than having the hospital own it. We did a little bit of work to look at it to say, if you choose it, here's your pros, here's your cons. And again, we like to make sure we're doing due diligence to show you that we're willing to look at these other models and present them, even if we don't recommend them, because it is going to come down to your choice. You get to decide. So summary, and we still certainly can take any questions you guys have, but this is really what it all comes down to. In the end, our report, our findings, our recommendations, this is what it comes down to. The community's will, desire, and commitment. As a community, can you get together to decide, do we want EMS? This is one of the most common things we'll ask folks in the interviews. is in this area and community, do you want to have EMS? Do you want an ambulance? And what do people say? Yes, right? And we ask, what kind of ambulance? What level of EMS do you want in your community? What do they usually say? Like the best, right? If they know the words, they might say paramedic, or ALS, but they want the best. So then what do you think our third question is? What are you willing to pay for it, right? How much does it cost? So part of this first thing about having sustainable EMS at its core is the community's will, desire, and commitment to it. So the community has to want it, have to need it, and have to be committed to doing it. It's either call volume or subsidy. And yeah, there certainly could be a blend. In order to be sustainable, you either got to be busy enough that you can bill enough that you can operate the system, or you got to get subsidy. Taxes, levies, donations per capita, however it's done. So generally, those are the two ways you're going to fund it. You either got to be really busy or you need to have the subsidy. Here, you're kind of in the middle, right? You've got a little bit of volume. The benefit, we keep saying this all the time, and I should probably just tell you why and call it out in a very obvious way. The reason we tell you that transfers are so important is even with Medicare, your base rate is your base rate. That's all you're going to get. But when you're driving, what's your loaded miles here to Duluth? 110 miles. You can now bill 110 miles at that rate. So your mileage gets reimbursed, even if it's at the Medicare rate of $27. Who cents? That'd be terrible. $27. But imagine those other insurances where the national averages are $40 a mile and you're driving over 100 miles. That's why transfers make the difference. Base rate is base rate, but the volume is being able to have those loaded miles. Accepting unproductive time. So if you're going to have EMS, the challenge with EMS is you have to pay for the cost of readiness, which means you're paying them to be there and they may not be doing anything. And so how do we recognize that your first 12 hours of your shift, you might be doing nothing, but the next 12 hours, you might be busy the entire time. So there's this unproductive time, which says in EMS, there are times that they gotta rest, they gotta nap. It's different than hospital and other systems where you an 8-hour shift or a 12-hour shift. Now, if you choose to do 8s or 12s, then you can decide whether that's something you want to do. If you work as part of the hospital and they choose to work in the hospital, maybe you do 8-hour shifts. It does change the FTEs a little bit, how you're balancing schedule, but it is one of those things to look at. And then as Tom said before, I'll just reiterate, we've got to lead it as a business, operating it as a system, finding and keeping the right people, so critical, demand the right single culture. So people want to come and be a part of this organization. You got to have that right culture. And that comes down to that leader and that leadership team. So making sure that the folks that we're bringing on are the folks that are the right fit for this area, right fit for the communities, right fit for their peers. You need strong leadership and management to make sure you have the right people. If you want to be sustainable, you can pay a lot of money, but if your culture is terrible and people show up there and they don't want to work there, they're going to walk out the door. So it is a key to long-term sustainability, is making sure that you've got the right culture and engagement. So obviously that's a lot that we kind of just threw out there. What have we missed? What questions do you have? What did we not include, or you need more elaboration on?
Yeah, you mentioned stakeholders. We actually talked with the owners of the energy service, the elected officials,
Yep.
and the city.
Yeah, we had elected officials, we had joint powers board members, we had other members. I wouldn't say we had all of them, but we certainly had, yeah, we met with Dina Tower, and again, I would have to go and look at the list of people we spoke to.
City manager, yeah.
Right.
Yeah.
That could be the counselor, mayor.
Sure.
We may have a different viewpoint.
Yeah, absolutely. And I think we always try, again, I can't speak if someone reached out to you and maybe the day didn't work. Yeah, I know there were a few. It is, we like to always gather as many as we can, but sometimes they can miss. Did we get up to Greenwood?
We met with them.
Yeah.
We did meet with the people. We didn't go out there, so they came in.
And we're the city, with everybody descended of the.
Oh, the Greenwood people were not part of the presentation.
No, I thought so. You need to go back tower.
Sure.
Yeah, we really haven't, this is our opportunity to introduce these thoughts to all, and so for us to say they're all behind it, that would not be a fair statement.
This is the first time Dusty's seeing this presentation.
Yeah.
Before we can go up. Meeting wall.
And we talked with several that either were community members.
But you haven't talked to them since
Who's that?
Saturday,
I have, yeah, I've talked to them.
within the last week and a half.
No, not last week.
I just talked to Quantum in a week and a half, but he hasn't heard nothing.
Yeah, and we didn't send any invite out for the meeting. But we did talk to several folks, community members, some elected officials, and folks on the ambulance. In each of the event, and there were ones that said, we understand we need to do something different. And I'm not gonna say that was Ely that said that, or Babbitt that said that, or Tower, but there were folks that were part of the organization that understood why this was being done and said, we have to do something different. There are others that said, if it goes to the hospital, I want nothing to do with it. I mean, we heard the gamut one way to the other, right? And again, that's part of us trying to understand the culture today. What's the environment today? And so again, one of our first observations was be a little tense at times when you talk about this.
Greenwood did a study 2 years ago, I think 48 or 58 dollars. And we had a copy of them. Name that.
Yes, Patty?
Greenwood has been responsive, not. So I will let just everyone know that I was contacted by Greenwood Township Senator Hochschild, both calls and or email, and we were unable to attend. It's not that we are not interested in finding the information, but
They are gonna have a pilot meeting, 2 of them in order to Minnesota. 30 million and 56 million left over. That's gonna be in this game, they're gonna explain a lot of stuff. Might even be money that will hand.
Yes.
Maybe to come back to the earlier questions, and just, I don't think it's been answered, not saying you guys can or can't. But back to the 2008, that's where we were, is where you want us to go back.
Right.
What changed, and I don't know if we've heard that, what changed to make it better to go back now than it was to stay there? in the
Right,
first
right.
place?
Right.
Yeah.
it's the fact that if everybody is agreeable to one system that creates one license, and you get rid of that 35-mile rule. And that is, back in 2008, I can't speak if that was considered or not. It was just looked at as we were just creating, another nonprofit as that.
Yeah, and whether something changed, whether they just didn't ask that, because we even had to ask that question, because we wanted to clarify, does that fall under the 35-mile rule? One license with an address that can still have substations, and they said yes.
And the other thing that has changed is that volunteerism has dropped. Our resource pool has dropped. And today, 22% of the patients leaving the hospital that need an ambulance aren't going by ambulance. I'm sorry, 11%. 11%.
Anyway, but Nick was saying, 206, John Foss was the minister. He paid $40,000 for it. And for 2 years before we took it over, 208. The main reason was the hospital was a non-profit because of that money. So we didn't just take it over, the hospital had a 2-year study on it. $2 to do this. Not went to every one of those meetings. And at that time, we go back 30 years, we were all paying $5 a week, wasn't it? $30 total. That, they had a $40. They went, why would something like $2?
Yeah,
I understand. This is, the reality of where we're at. Everything has changed a lot since 2006 until now. The care needs of the people, the demographics of the community, just the expectations of patients and the tourists and the visitors. And when I have been talking to legislators and talking about reimbursement and how we can approach this, that is really, this is just one sustainable solution that we were able to develop. I can't tell you 10 years from now if it will still look like.
I can tell you now, for the sustainability of healthcare in this region, especially the role of emergency care, we have to be willing to look at these.
And I mean, and if you look back, again, historically, you've seen this happen with your schools, you've seen it happen with libraries, you've seen it happen with, I mean, so the, you know, recognizing individual communities having all of their own independent entities is something that in lots of areas you can look at and say they've changed it to be, try to become more efficient. And not saying that this model is just because of that, but again, I think the answer to the question is, we've seen so many changes in the last 16 to 20 years. How are we staffing people? Maybe 16, 20 years ago, they weren't having trouble getting patients out of the hospital to the next hospital, but now today they are. You've probably had some population growth, and so now there's been a higher need for EMS and a higher need for transfers. These larger hospital systems are creating more and more specialties now that you can get somebody to a higher level of care closer that maybe before wasn't an option. And so just all the demands of healthcare have changed. And I do think one of the important things too is, generally speaking, the leaders in these entities have changed too. And so I think we're at a different point now in 2024 than you were back in 2008. And my own personal opinion is, I think in 2008, they tried something different and it worked for a while. And what we've heard time and time again in our interviews and what we saw with the data is you tried something different and it worked, but it's not working anymore. So how do we continue to make sure that when you call 911, an ambulance will show up? How do we make sure when the hospital calls to get you down to Duluth or somewhere else, somebody shows up? So that's where we saw the gap, which is kind of what spearheaded this. Yes.
How receptive was the hospital board to moving it back to the hospital? I know Patty's the employee on the board. How did the board feel about it?
I won't put any of the board on the spot and ask you to respond, but here's what I'll tell you. We presented the information and said, we know there's a lot of information. You guys probably need to talk about it. So we didn't put it up there and say, all right, everyone vote yes, and everyone, you know, and I know I'm kind of being humorous, but we didn't really ask. We just said, here's our recommendations. You as a board probably have a lot to talk about to discuss what comes next. So.
But as the owners of this project, they had the option of having this meeting or not having this meeting. And so they wanted to have this meeting to share this information with the community. So you can certainly talk to the board members yourselves about, you know, what their take is on it or what they think is going to be the best solution moving forward. But we're here at their place. Sir.
You know, I think it's important to remember that it's the first meeting, information is presented, and it's our job to bring it back to our boards and councils and discuss it, just like the hospital board did or we're doing here. There's no decision that's going to be made in this instance, but I think it's important to take the information. My personal approach to it is follow the money and lessen the subsidies on the taxpayers. So I'm interested in any models that lessen the impact on the taxpayers.
Yeah, such a valid point. Phase 1 and 2 is gathering data and presenting it. Phase 3 is really the work, and we haven't even started that. This is the beginning of this. This is not the end. So this isn't the be all end all. This is the beginning of what comes next for your area. So well said.
Back.
I just wanted to let you know that, I don't know if anybody heard, but over at Grand Rapids, the ambulance was owned by a private party. That ambulance just got bought out by, Royal, and besides Grand Rapids, they're looking at Pewaukee, and that's what Pewaukee has their city ambulances, whatever. And it looks like they may move in there as well. Just food for thought.
And this is not so unique. I probably said this. It's not unique to your area, the challenges you're seeing. That's why so much of our work is busy right now, is that we have all of these communities that are trying to figure out how do we fund and provide EMS, long-term, reliable, viable, sustainable, and equitable. Because so many, 80% of the ambulance services in the nation are still using volunteer labor. So 20% of the ambulance services are full-time. And the reason they're full-time is because they're in busy populated areas. They're doing 80% of the calls because they're in Minneapolis, they're in St. Paul, they're in Duluth. So 20% of them are doing 80% of their calls. So they have the call volume to generate the revenue. But the other 80% are doing the remaining 20% of the calls across the nation. So this is you could go back to the Reagan era, and I'm not making this political, but they cut federal funding for EMS when they did that balanced budget. It was supposed to be funded by the feds, and when that went away, the communities were left to fend for themselves, and many communities, just like yours, figured out what you needed to do to make sure you had EMS. And it's worked for that 60-some years, and now we're at this point that says, we've got to do something different. We can't keep asking volunteers to continue to give their time and then expect that we're going to continue to find more volunteers to continue to give their time. Yeah, we've had some assessment work where they've asked us, so what happens when the local provider closes? Similar, it's a privately owned ambulance service in a rural community in another state. And they said, so they're talking about closing. So what is it gonna take? And part of the reason they were closing is the city didn't like that the ambulance was asking for a $300,000 subsidy. And so they kind of got into a tit for tat, and the service said, you know what, we're done. We're old, we're retiring anyway, you figure it out. So we ran the projections for that city to duplicate the system they had for $300,000 a year in subsidy was over $2 million. And so that's one of the challenges is if you were to bring in another organization and they run the numbers and they don't have the call volume to do the service, but you needed the service, they're gonna ask for a subsidy. And that subsidy likely is gonna be a little bit higher. So
I had a chart here, the majority of the ambulances, I think it's 56% are owned by the city, then private like ours, and then the hospital. So the majority of it, right? I think Virginia and Nashua are owned by the cities, right? As well.
Yeah, sir, you had a question.
Mine is related to what everybody's been saying here. I was kind of expecting one of the options to throw out was being, what if a company picked up all 3 of our licenses? And I wouldn't expect that that's kind of, I don't think that's a good idea. I think what we're talking about here is probably too expensive, but I think that would be a good option to have some numbers around, be able to show that, you know, this could be an option, but it's also not a good option.
and when we take the average number of what we say it costs to fund an ambulance 24/7, you'll see that the number that Tom had up there is it's roughly $1 million a year for one ALS ambulance. So it's paramedic EMT 24/7. And that's a general cost across the nation. That's salary dollars, expenses, disposable supplies, overhead, cable, right? All the things you need, $1 million a year. BLS was at 735. So you can kind of put together the math here to say, so as a community, so let's bring somebody in who's private. What do we need? Well, we want 4 trucks. So we want 2 here in Ely, 1 in Babbitt, 1 in Tower. It's gonna be $4 million. And so again, it depends on the organization that comes in, how they would be able to maybe figure out revenue versus some sort of subsidy, but generally speaking, it's gonna be pricey.
Well, the ambulance outfit and Louis, we checked one year, they would come here, they said, no way, there's not enough customers here.
Yeah.
And I talked to the mayor of Nashua, when he went to Nashua couldn't get over to come and take their vote.
Yeah.
He said they'd have to call Hibbing, Grand Rapids.
Yeah, we had the same experience.
Yeah.
None of them will
Just jump in.
We were talking about the subsidy.
So the $4 million in expenses, you said in the current reimbursement, you lose 1.4 million under the current structure. You're saying under the new structure, they own under the current structure. What is the number with the new structure?
Yep.
They started that.
Yep, if it's owned by the hospital, taking the benefit of the cost-based reimbursement, it would net a profit.
How much?
We had the number, it was 50 to 75,000, something like that. Yeah.
But it's 1.4 million more.
Yeah, yeah. And again, it all comes down to the amount of Medicare folks you transport and being able to get that 101% back on those.
Cost. Not of charges. So
Yeah.
I'm just saying that if you switch to the service system, that's 1.4 million. Correct.
We wouldn't net it, but you would that would come into the system and your net revenue would be just under 100. Yeah.
You talked about the 20% carrying 80% of the
Calls.
calls. Are those 20% doing any of the transports like we do from rural to, you know, the
Most are. Most are.
So it isn't just 911, they're doing all the.
Yeah, most are certainly do that. I mean, Ben and I have been across the country doing these assessments. And the assessments that we do for these rural services, they are accounting for interfacility transfers and 911 calls, absolutely.
But they wouldn't be getting the 101%.
No, it's just that it's so busy. You're talking about an ambulance crew on for 12 hours doing 14 calls. So they are so busy that even getting 39 cents back on the dollar because of the busyness of their system. And it would vary, right? So again, if we just use Minneapolis, St. Paul, Hennepin EMS does 911 and doesn't do transfers. Alina does both. North Memorial does both. So some do, some don't. But it's just about the sheer volume of calls in their area that allows them to then generate the revenue because they're so busy.
They can make it with the right volume they have.
Yeah.
We have follow-up questions, are those the best?
Yeah, absolutely. So these are all four of our contacts, and I know Patty has them too. And so depending on the question, we'll refer to either myself or Tom or Aaron. Aaron is the owner of SafeTech who does all the analytical behind the scenes. So we may forward you to him depending on what your question is. Yeah.
And I would prefer, I know these guys usually include me, but just so you know, when you contact them, you know, they want me to contact.
Yeah, I mean, in fairness, the hospital is the one that funded the study. So that, yeah, and it's really just making sure that everything's transparent.
You just copy Patty.
Sorry.
We just copy Patty on the emails, make sure she knows.
I will.
Yeah, we initially did not bring packets, as you can tell, and part of that is there's very bullet pointed PowerPoint versus all the devil in the detail. And so you can see how it can be difficult to kind of see some of it. So we often don't bring copies until the person that's funding it decides they want it to be distributed. Now, with enough of you in the room, I think, you know, yeah, Patty's willing to share some of that. At least you guys now have the context that goes with it.
We'd like to thank you for coming tonight. Your